the Erie County Medical Center Corporation on January 25th. We'll call that meeting to order. Our first order of business is approval of the minutes. With that, see, my right hand, my left hand has moved for approval. Mike Seaman has seconded that. Anybody have any discussion or comment about the minutes? All in favor of acceptance of those minutes?
Aye.
Any opposed?
Aye.
Okay, so those minutes are then approved. The first item is a resolution of the corporation accepting the consultant's report, and I'm going to ask John Kwiatkowski to talk to us about that.
Okay, you may recall that at the end of 2020, we did miss an administrative covenant related to debt service coverage that required for our bond documents us to engage a consultant, which we did. Went through that process. The consultant performed their work. It was Fried Maxick, performed their work through the tail end of 2021. And as such, that report, which their work was really required to provide recommendations in the report for operations to achieve debt service coverage ratio. That report was issued late December. They completed their work. The bond documents also then require the board to accept that report on behalf of the corporation. That report itself has been included in your materials, about midway through the materials. Fried Maxick, as the consultant, did have the benefit of time in doing this report. So just to, at a high level, the report and the work they performed was looking at 11 months of actual performance, plus a projection for the rest of the year, all to culminate in their report basically by showing compliance at the end of 2021 with the debt service coverage ratio. Of course, that's using a projection, but the actual results we'll talk about later in the meeting do approximate the projections. And so the resolution, among other things, asks the board to accept the report and accept the steps outlined in the consultant report, and allows us to distribute the report to the bond trustee and the county.
Anybody have any questions for John?
Just one. Did anybody really care other than us?
Well, as a matter of process, the bond trustee was checking in on a regular basis, as was the county, as they're supposed to do under the documents.
Mr. Colucci, do you have anything to add? I see your name on my cheat sheet here.
Thank you, Jen, and Happy New Year to those I haven't wished it to so far. No, not really. This is the last step in a 3 or 4 step process that is set forth in a document known as a master trust indenture, which is a fancy word, but it really just means a contract that the corporation entered into back in 2004. And in order to remain in compliance with its bond covenants, the corporation needs to generate the report, which it's done, and the board needs to accept the report. So that's what the board is being asked to do at this time.
Do we need a motion to accept that resolution and accepting the report?
Yes.
Yeah, I would ask that I have someone make that motion.
So moved.
Motion made by Gino Lucy and seconded by John Danby. Anybody want to talk further about that resolution or report? Please signify your vote by saying aye.
Aye.
Any opposed? Okay, motion carries. Our next item of business is the medical dental staff meeting minutes. Do we have Dr. Cummings?
Yes, thank you. Thank you, Jen. First, of course, I want to echo everyone else's accolades to John. I've really enjoyed working with him personally and professionally the last couple of years, and look forward to doing that with Jen going forward. And also, of course, acknowledging Karen's, leaving of our family, only in partial, but still she and the nursing staff is the lifeblood of our hospital. And you know, it'll be a big loss to us, but she leaves a wonderful legacy. For folks consideration today, we have the appointments for both November and December, as we did not have a medical executive meeting in the month of December. So we have 21 initial appointments and 22 resignations, and then 77 reappointments, which to me actually is really the thing that matters, because doctors will come and doctors will go, but most of our doctors will stay once they're here and part of the ECMC family. And if the board would indulge me for just a moment, I also would like to just acknowledge a few people. Obviously, we've all been struggling during COVID. It's been really tough with staffing and with all other things. And, you know, we put a kind of a call to action to our medical team, and we had many people step up. I'm not going to list everyone, but we had Dr. Zach Wickard, Dr. Thomas Majewski, Dr. Christopher Schaefer, Dr. Paul Shields, Dr. John Fadima, who all stepped up to just simply help Apogee and our hospitalists cover the load that was becoming unbearable. And so it's just really just a testament to ECMC. So with that, for your consideration are the minutes from the last two board med exec meetings, as well as our credentialing, and I'm certainly available for any questions.
Yes.
So, can we have a motion to receive and file the medical dental staff meeting minutes, please?
Second.
Dr. Graham, Mr. Sealer, thank you. All in favor?
Aye.
Any opposed? Okay, so that's been received and filed. Do those minutes, Dr. Cohen, do those minutes include the appointments and reappointments of the chief of service, associate chief of service?
No, actually,
Right.
that's a separate resolution, because the bylaws of the institution require that the chief medical officer present to the board the chiefs of service for approval. At the beginning of each year, I generally present the entire slate. It includes two new appointees who have been appointed to one-year terms during the past year. One is Dr. Keith Crable and for the laboratory medicine, and the other more recently is Dr. Yaron Perry in cardiothoracic surgery. Three other individuals are moving from initial one-year appointments to the more traditional three-year appointments. Those are Dr. Anthony DePlato of anesthesiology, Dr. Richard Spiro in neurosurgery, and Dr. Suzanne Griffiths in obstetrics and gynecology. The remainder of the slate remains unchanged. They are three-year appointees in 2020, and they will need to be reappointed next year. So I would present that for the board's approval. Thank you.
Thank you, Dr. Murray. May I have a? Thank you. All right, we've got it. The motion, and then seconded by Mr. Gandy's. Anybody have any questions or comments relative to that?
Just one question, Brian. How many of those chiefs of service have joint faculty appointments? Would you be?
Good question. I would say almost all. I would be hard pressed to say there might be maybe one or two that do not. I think Dr. Levesque in rehab does not have a university appointment, but I think that's really about it.
Are those usually the chairs of the departments?
No, they're not, and they're not invariably the chairs. No, many of them, some are, but many are not. They're usually the most prominent providers at our hospital, because, and that's important, so that we have somebody on site who's engaged.
Thank you.
Any other questions? Okay, then let's take a vote on that. Everyone in favor, please signify by saying aye.
Aye.
Any opposed? Okay, we've made those appointments. If you look, I think at the end of your board packet, there is a list of the the regular and then the annual meeting. The regular meetings for 2022, and then the annual meeting for 2023. They typically will stay the same, Tuesdays at 4:30. The last Tuesday of the month at 4:30. That's how we've scheduled them because it seems to have worked for everybody. And so we've set them up that way. And I would ask for a motion to approve those 2020 meeting dates.
So moved. Second.
So moved by Gino, seconded by Mike Seaman. All in favor?
Aye.
Any opposed? Terrific. Thank you very much. That takes us to reports from our leadership team. I think that I'm not sure that our president and CEO has another report.
No, I do not. I just want to mention to the boards that John's going to talk a little bit here about finances and stoppages of surgeries that, I'm in particular spending a lot of time right now between now and the budget advocating for the organization and asking for help. We with the stoppage of surgeries put us in a pretty tough financial spot. We're not alone. The other obviously systems in the market have their challenges, but obviously as being high Medicaid organization, we feel it more than others. So the recent budget that was passed helps in some ways, but in many ways, public benefit corporations are carved out of the increases. So we're working with our fellow public benefit corporations to look for assistance from the state moving forward. But it is a situation that we got to put the pedal to the metal on that. So I know that we talked in the executive committee meeting about doing some advocacy work. We've as we look year to year, it's about $79 million of cash that's come off our balance sheet, which is not insignificant. So just want to let the board know that we're on it. We're going to keep pushing as hard as we can with our state officials and make sure that we get the resources we need, especially in light of the fact that we have to stay competitive in the marketplace with our workforce. So it's going to be a tricky dynamic this year, but we're going to keep fighting for it.
Yeah, and thanks for all those efforts. With that, I'll turn it over to John Sly for our report from the Chief Financial Officer.
Okay. Thank you. As Tom said earlier in his report, we've been extremely busy. Jeffrey, if you just shift to the next slide. Thank you. It's a little tough to see, but there's a lot of red, as you'd imagine. December saw its own set of financial challenges, especially given the suspension regulatorily of surgeries now extending to the outpatient starting in December, whereas starting in September, we had suspended our own inpatient elective surgeries starting on around September 27th. But you can see it here in the statistics. Inpatient cases, discharges down 19%. Our average length of stay, which has been talked about significantly, continues to increase, causing significant challenges within the organization operationally. But again, that's here, and then the acute side at 10.5, and that's actually grown into January a bit. But more specifically, when you look at general surgeries, both inpatient and outpatient, down 42% and 35% respectively from our budget, really exacerbated the issue for the month of December. When you combine all those pieces for the month, that impacted our revenue by about $6 million. Now, next slide. So when you couple that with the challenges we have on staffing, the increasing costs related to that, premium costs, temporary agency costs for staff that are exorbitant, additional COVID-related costs, cleaning costs, resulted in a $9.6 million loss from operations for the month. Now that's before we do our year-end look and before our year-end adjustments. So you can see next to that on the dashboard, we have a loss of $24.7 million for the year. That does include the benefit of several non-cash year-end adjustments that we'll talk about in a moment. But nonetheless, we still are seeing significant losses here at ECMC. A couple other items just on that slide, real quick. Okay. So FTEs, we've mentioned, have been below budget, continue to be below budget, primarily related to staffing challenges we've had. That's in green because it's below budget, but not really by design. Really been trying to hire additional staff. That's hopefully a temporary situation. You know, we are looking to continue to hire. We've had some significant numbers come in the last month, so we're hoping to see that increase. Really try to offset some of that temporary labor and premium labor costs. Days cash at the end of the year, tracking about 89, a little bit above where we had anticipated. But again, really temporary in nature as we look at some of the immediate payments shortly after year end for payroll and loan payments and some other things. Next slide. Thank you. So when we really step back and look at a year end in 2021, and it's a busy slide, but as I said, for the year, with all in, with the CARES Act funding, we have about a $24.8 million loss. But really, when you step back up the page a bit before the CARES Act funding, we lost $35.9 million. That does have the benefit, as I said, of a couple of non-cash related actuarial year-end adjustments, which we typically see. Sometimes they're positive, sometimes they're negative. You can see that displayed here, just compared to last year on the pension side. Both really have to do with benefits, but you know, from an operations perspective, we really were impacted by January, February, September, October, and really through December in the surgeries that we've talked about throughout the year. And that's what's driving the losses before those items.
John,
So,
can I ask you a question?
Sure.
As far as IGT, with the pandemic, does that increase it at all? I mean, as far as engineered care and stuff like that, are we seeing more money coming from IGT?
There has been an increase in IGT over the years, but it's really not pandemic related per se. It's really just looking at our losses related to those Medicaid cases, to the indigent cases.
Yeah, it's kind of, you know, because of the CARES Act dollars, we have to be seeing, since it's kind of, it doesn't really hit for a couple of years later. So, you know, what's happening now will affect IGT a few years down the road, and we don't know what's going to be happening with IGT. Obviously, there's a lot of advocacy from public hospitals to continue the support, but you know, the federal government will be looking at that too. You know, we've been successful, both the Healthcare Association, American Specialist Hospital, and all public hospitals across the United States advocating to not have reductions in that so far, but we'll see. Time will tell. So.
Do we have an anticipation of what we'll get, let's say this year from last year in IGT?
Yeah, I mean, this year in terms of cash, we anticipate receiving roughly the same amount as last year because it's, as Tom said, the payments that we're getting today are really based on 2 to 3 years ago in the activity then. So it takes a little while to catch up. Any increases we may see because of what we're seeing the last couple of years, we really won't see in cash for 2 years down the road.
John, would you share with everybody the agency issue in real terms? Because I think that's an eye opener.
Sure, and I'll ask Joe to jump in, but just for the current month, you know, we essentially have to hire temporary agency staff to cover shifts because of the staffing challenges. The cost that we're paying for those people is $100 to $150 at least, I think, higher per hour than what we would otherwise be paying for those staff. So the cost itself is significant. just for the month of December, that additional premium cost for us was over $1.4 million.
That's per hour per person.
Per hour, per person.
Employee, that's a-
Yeah, so this is obviously a national issue. And obviously a local issue with the Catholics in Kalana. We've had, there's traveling nurses that are not traveling very far and going in and being hired by these agencies. The Attorney General, I believe, is looking at the price guide around this issue. They're going to have to prove that the agencies are getting the money just as much as the employees are. And we're also looking at different, the Healthcare Association is looking at different ways to maybe regulate what's going on around this, but it is costing the system, healthcare system, a lot of money right now. And, it's unfortunate, we don't like that, we don't like having to hire agency nurses. The unions don't like having to hire agency. Nobody likes it, but it's right now a necessary thing to be able to staff units. So it's a difficult situation for everyone. And I think we need to figure out with the feds and state how to regulate it so it doesn't continue to hurt us the way it is.
So how much of that goes to the employee versus the agency?
We don't know. It probably varies agency by agency.
There's no way of cutting them out?
Well, no, the problem is, there's no staff in the pipeline to hire. We'd rather hire ECMC employees.
No, I get it, but there's no way of just eliminating the agency and having these people come in and we pay them versus paying the agency to.
They have to come in as employees, they have to come in as employees.
Like they come in as the agency employees. Like, I get what you're saying, like, can we cut the agency out? But the agency typically would hire that person, and I'm sure that they have a contractual obligation to not do exactly what you're saying.
Yeah.
Right.
And we hire it on a temporary basis. I mean, there's no intention of doing this long term.
Right.
And it creates a very, difficult dynamic, right, in the institution with our nurses who are employed, knowing that somebody next to them is making the kind of money. Albeit temporary, it's not a career situation. But it is, in all of our hospitals, it's not a good dynamic. And again, it's the national problem, but we're hopeful that as more and more, and I mean, we've recruited a lot of individuals since August that I think see the longer term trajectory for their career versus a short-term assignment. But I think as time moves on, we hire more people, we'll be able to reduce the agency folks.
I think one of the things too, we continue to offer per diem and part-time positions with the organization. So Karen and her team tries to have a number of different nurses who want to work very odd shifts to help us through the time. They've been invaluable, but so we do try to offer some unique situations for employees.
But the enormity of the situation, unless you really drill down and speak to the specifics, it's between $100 and $150 an hour per nurse on all of our shifts. Plus they get paid travel and housing and meals. So if you're a young nurse who is not bound to be here or stay in one place, the opportunity to make serious dough is almost, how do you deny it? And that's to Tom's point, it's a national issue, but it's costing us millions to do that.
Do we have nurses that are resigning from here and then
Yes.
going out and coming out? And are we able to keep track of that so that we do not rehire?
Oh yeah, we don't rehire them here.
Oh, okay,
Yeah, we do work with the agencies to make sure that doesn't happen.
okay.
But they could go across the street, right? They could go.
That's right. That's my point.
Yeah, I mean, that's a difficult
Can't stop that.
situation. There's no immediate end in sight.
Right.
Really, yeah. I mean, to John's point.
So we talk about millions.
Irresistible.
No, we talk about millions of dollars and the impact of the CARES Act and all this stuff. We literally have nurses, and to Bishop's point, we have nurses that we've been charged $100 an extra hour that are probably seeing, well, some portion of that, but they're certainly not seeing all of it.
And the tough part when you look back in the history on the charts that we saw earlier is 2 years ago, we weren't using agency
At all.
nurses at all.
And we're probably one of the few, if not the only institution not doing that.
Joe, how many do we have, do you think?
Up 40?
40.
It's
We've had as high as what, 100?
Yeah.
So
We've
what
been
do you,
working at reducing it as we've been hiring people.
so what do you see changing in the next couple of years, being that you had 583,000 people leave healthcare last year?
Yeah, I mean, I think that, there's not the pipeline that we need, to your point, to replace, but I think we're gonna see a lot of competition for the new graduates. And obviously people moving from other places, we've again, been successful, because of our culture. And frankly, I think our benefits also help us, in making sure people have a life-work balance. But we're gonna have a lot of pressure, on us to also compete from a W-2 perspective, which is gonna be very difficult considering the finances that we are facing. So, but we're gonna have to do it to remain competitive. It's gonna be a tough dynamic.
Do we see this all the way down to the CNAs?
Yes. Yeah.
CNAs might be tougher.
Right.
The turnover is unbelievable.
But I speak at every orientation and, the classes have been pretty full. I mean, there've been 50, 60 people every other week. So the teams are doing a great job. The HR and nursing and Terrace View, and everybody's been doing a great job.
Okay, so I think if we go to the next slide, just to reiterate our close cycle here for the board. So we've really completed the preliminary close. We are still trying to finalize a couple things, waiting on a few things that I'll talk about in a minute, the largest of which is resolution around the ask around the phase $4 from the CARES Act. We don't have resolution on that. I'm supposed to get some information this month, but we'll be finalizing the close this in the coming February. The auditors will start soon. We'll get that all completed. And then our annual report and the public filing, the annual report will come back to the board by the time March comes around, and we'll have to file that by the end of the month. Just to keep everybody's eye on how we track our COVID-related impact, we're up to about $123 million in total. Again, this is really trying to track the pure COVID-related costs. It does not have things like some of the indirect costs we were just talking about, the differential and agency costs, for instance, or the pension-related costs we saw last year. So if you really think about this compared to what the true overall impact could be or is from an expense perspective, it's probably much higher, but we're trying to keep this tracked along the same guidelines that we use to track it for reporting for HHS. Next slide. So just as I was mentioning, phase 4, we are anticipating some potential updates here coming in the next month. The other item here that I wanted to talk about, Tom already spoke about the budget bit, but our public hospital funding work group, we continue to advocate with the other public hospitals in New York State for additional funding. I think that's all I have from my report. Are there any questions that we can answer or anything I didn't cover?
John, I know, and this might be covered in something else, but I know in executive, we talked about the nurses' contract, right? And so I'm wondering how that, how's that playing into the whole budget, knowing that you've got a nurses' contract that's coming up. And also I wanted to ask, because I think NISNA, we only represent a small part of that. So are we negotiating, from a, statewide position? Are they negotiating from a statewide position, or is it just, our local nurses?
Yeah, so both our NISNA contract and our CSCA contract are up at the end of this year. So we'll be having negotiations this year. The blue collar contract, over the years, we've worked with the county and the unions to separate our negotiations, both for white collar and for NISNA. AFSCME decided not to do that. So they are actually currently in negotiations with county, and we have a seat at the table, but it's really county statewide driven. So that's still kind of in flux right now. But those two contracts do come up. They pretty much negotiate local. There is some state involvement, but it's pretty much local and local representation, as well as teams here, obviously, that are elected from our ECMC family that are on the union negotiation team. So we will be entering in those negotiations at some point this year. And to your point about finances, it's I've said before, I feel like a little bit like Alice in Wonderland, because we're coming to the table with no money in our pocket, but we know we have to compensate our employees fairly competitively. So it's going to be a challenge. But we do, if we're going to recruit, we're going to have to be competitive.
So Tom, when we do the local negotiation, there's no comparison of what's happening around the rest of the state. It's just
there's reference to what's going on around the state, but I can say from last negotiation, we I think they might have brought some things to the table that are going on statewide. We did also as suggestions. And so, but it's not, there's statewide initiatives, if you will, but there's not necessarily at the negotiation table, a statewide representative, for example. There's local representatives, but they pretty much leave it up to the local. If you look at, our contracts versus some downstate, they're very different. Not very different, but they have a lot of points of differentiation.
Anybody else have any other questions for John?
Just a comment. I just want to give John thanks. The county had a shortage of the main drug for tuberculosis. Was it rifampin, I think? Mm-hmm. And John, the purchasing team were able to get us a several months supply very quickly. So huge thank you. We would have been out already if not for that. So thank you.
Oh, thank you. Great.
One thing, if there's one thing to be taken from John's report today, is of all the numbers that we've talked about, the 79 million is a number that makes us whole on our balance sheet, correct?
It brings us back to previous levels, yeah.
Brings us back to our previous levels. So we are about to begin a very aggressive effort that does not include us with the upstate hospitals, that does not include Kaleido or the Catholics. We need 79 million bucks here in this building. And Jen and I and Tom and Andy and Peter have talked about taking that to the next step, which includes some type of public pronouncement that says, for all of the reasons that we've articulated over the years, including the fact that we're a Medicaid heavy hospital, that we take care of the sickest people in Western New York, including those that can't necessarily pay. 79 million bucks, Bishop, to your point, relative to our negotiations with the nurses union, is what we need and what we need right now. And hopefully, I know Tom has had a conversation with the governor and the governor's staff about making that happen. But the board is going to need to coalesce around the advocacy for that amount of money as quickly as we can get it. Mike?
No, I mean, the bottom line is these are dollars that were lost that we can't invest in our people, our building, or our technology. So when I say technology, obviously it's beyond just, robots, but, really our ability to take care of our patients. So we're going to continue to fight for it and continue to make people understand that, we're a not-for-profit hospital, public hospital. These are the types of consequences of it. The CARES Act dollars and the way that they were given, I don't think accounted for the losses that we received, and other institutions that did, I think. And frankly, the stoppage of elective surgeries is probably the hardest impact that we've had. And we've been unique in Western New York around that. So early on in the pandemic, we, I think rightly so, stopped them to be prepared for a potential surge. And it came, but didn't really come at the level I think people thought it was going to come at. And we were empty. The building was empty. If you remember back then, we did furloughs, we did layoffs, we did all those types of things to try to stem the cash flow bleed. But we haven't been able to do that when we stopped. I think it's 4 times So it's been, you know, and we're unique in Western New York around that. And so that's why I think us, Klein, the Catholics, we've taken an impact harder than most. And we get it hit even harder because, as John has pointed out, our payer mix is the way it is. So we don't have the commercial to be able to draw from.
Right, and so Tom makes a great point, that 79 million, John and his staff have done a tremendous job in accounting for all of the CARES Act money, all of the loans and forgiveness and all of that, and that's a net number. So you can, not that I would suggest you ever forget the rest of the numbers, but the takeaway is 79 million that we need in this building right now, irrespective of who else gets whatever they're gonna get, right?
Hey, Tom, I'm sorry.
No, and that includes all the other hospitals in Nassau and Yonkers and wherever else, and our colleagues, you know, down the street. So it's 79 million.
On the elective surgeries, I know there was an issue with a lady that needed back surgery, and she pushed to have that done, and she was able to. Are we seeing any of that happening where elective surgeries are really not elective and people need to have these surgeries? Are we seeing those get done?
Yeah, so I think that was a unique situation, and at the end of the day, you know, there's those cases that are kind of in the gray area, that there's a conversation about whether somebody's in a lot of pain or not, you know, and we have to kind of follow the guidelines. So, you know, frankly, I don't think that case needed to get to the paper for it to get done. It was going to get done anyway. But we talk with the surgeons. They have meetings, I think twice a week now, Andy, right, with the surgeons.
6:30 a.m.
That's right. To look at those cases and look at what should be done, because people, you know, may have ambulatory issues and those types of things. But so because to your point, you know, everything's not elected, right?
Right.
You know, so there's very little that's actually elected if you really think about it. So, you know, nobody wants surgery. But we do have strict guidelines from the state that we have to follow, and we've been doing that. So.
And most of what I would say is, like, kind of, we do have a surgical review committee, a group of doctors that work along with Jim and Mark LaBelle, try to triage as many cases that need to go to the OR sources that we have. They've done an unbelievable job. And I have to give them kudos. There's been a lot of doctors that have been with us through the whole pandemic at 6:30 a.m. Tuesdays and Thursdays. And if there's any issues where they think that the case shouldn't be done, they review it and talk to the various surgeons. And so that case is a really kind of an outlier. We've been able to, the team has done a good job of get cases that are urgent or whatever needs to be done, go through.
Yeah. Okay. Thank you very much, John, as always, for all your hard work putting that together. We'll move on to the reports from the standing committees. I'll report on the executive committee meeting. Not to be repetitive, but it is all about the money that we don't have, right? So that's all we talk about all the time. And you can rest assured that everybody is working as hard as they can to find that money. And we're working on kind of a comprehensive strategy of plan of attack, if you will, on how to do that. So more to come on that, but I think a lot of what we talked about in the executive committee was that and some of the other things that Tom has already addressed. So I'll hand it over to Mr. Seaman for the finance committee.
I had a chance to talk to John about the performance of December, but I wasn't able to attend the finance committee. So Darby chaired that, so I would defer whether Darby or Ben, who also I believe was at the meeting, do they have anything else to add or any additional questions?
No, I think John did a great job, and I think Mike, as you always thank in every meeting, I want to say John and Tom and Andy, Andy have all done a great job being finance informed every step of the way throughout this entire process, and they're really doing a lot of work behind the scenes to keep us on track. So, but I have nothing else to add.
Thank you, Darby. Thanks, Darby.
Thanks. With that, Mr. Bennett, would you like to report on the building and grounds committee? I think you're muted.
Am I unmuted now?
You are. We can hear you.
Can you hear me now?
Yes, we can.
Okay, we had a meeting this afternoon, our normal meeting right before this meeting. And we reviewed a number of little things that have been done. They're not little, but Jim and Andy take care of it. As you know, the windows are done, the roof will be done this summer. One of the things that we do that I was somewhat surprised, but we had to rebid a very sensitive thing in a sterilizer situation because they come in more than expensed. We're trying to do that. I know we had a water break in the ED, and I think they're going to talk about that too, because that was a major thing that's been corrected. So they continue to do a lot of in-crew work, and save us the money of contracting. So Jim Turner and Andy are doing a great job.
Thanks, Ron. And I might point out, I'm on that committee, and Jim Turner is a wonder. So Jim, if you're listening, kudos to you. The logistics involved with getting all of those things done is beyond comprehensible. Tino, would you like to talk about the investment committee?
Yes, the investment committee met several weeks ago. And some of the questions at the time of the meeting were about the stock market. So, we thought we were a little concerned at that time. So you can imagine where we're at now. So it'll be an interesting next meeting when we talk. But at the time that we talked, it was as usual, slow and steady. There was some minor changes that the group recommended, but overall, the consensus was that the investments were doing well, and that we'll continue on that trajectory. John?
Yeah, the only thing I'll add is that the consultant did have some recommendations that the committee acted on related to a fund that had previously been invested just in money markets, garnering essentially zero return, just to move some dollars into equities and into a balanced mix that is in accordance with our policy. So that was done, and I don't know exactly when it was executed, but I think it was actually executed in the last couple of weeks.
So we don't know how it worked out yet.
Not yet.
Tough time to tell that.
Too early to tell. We're not-
Especially
Like I said, the next
yesterday.
committee meeting is going to be very
Yesterday?
interesting.
Good news is we're not market timers.
Yeah, right.
Yeah, right, day trading. Mr. Chapin, would you like to report on the post-acute quality improvement committee?
Yes, excuse me, yes, I would. The committee met, the post-acute committee of Terrace View met for its final quarterly meeting of 2022 on December 30th. We addressed our typical areas of concern, which somewhat mimic the monthly staff reports. The medical director, the COVID-19 update, the Department of Health update, staffing crisis were all addressed. The very brief minutes are contained in your board book. We plan to continue in the upcoming year with the same schedule. Once again, I ask that we would like some more people on the committee, and that one thing we're going to consider before the March meeting is to come up with some new topics, new areas of concerns. The change at Terrace View with Dr. Shields and his staff is somewhat remarkable. And I've been on that committee for a while, and I've seen a lot of changes, but this has been very positive. If anybody needs any more technical information, please feel free to call and ask Andy and or Pam Lee. And there's always Mr. Seaman, who's willing to jump in and help us. That's all.
Thank you very much. And is Mr. Hopert with us?
Yes, I am. On January 11th at 8 a.m., we had our board quality improvement and patient safety meeting. We had 4 presentations. The first one was the Commission on Cancer. by Dr. Katie Grimm and Dr. Saurin Popit. Second presentation was on a surgical, Mark LaBelle, nurse, RN Mark LaBelle. Third was anesthesia by Dr. Anthony DePlato. And the fourth and final presentation was on Terrace View Long-Term Care by David Denny, our interim administrator. If anyone would like to comment on any of those that reported in this, on the board meeting, please speak up. If not, those are detailed in your minutes. Thank you, Madam Chairwoman, and congratulations.
Thank you very much. I appreciate that. Does anybody have any questions or comments with regard to the standing committee reports? Okay. So I think now next we will, I would like to entertain a motion to go into executive session to speak about contract negotiations, personnel matter, and a legal matter. May I have a motion?
So
By Dr. Grimm, moved, seconded by Bishop Badger. All in favor? Any opposed? Okay, we will be in executive session in a minute. Okay, so we are back from executive session. And is there anything that anybody would like to say before we adjourn? Well, there's something I would like to say then. I would just like to thank everyone for their confidence in me. As I said before, have some big shoes to fill, but I'm not letting them go anywhere just yet because I value this council. And thank you to everyone on the board for all of your hard work, and thanks for continuing to serve. And I look forward to having a year of problem solving instead of more problems being thrown at us. But despite the fact that we don't have any control over that, I wanted to thank not only the staff of the hospital, but the executive leadership team for really making, as I said before, making it through the past couple of years in a fabulous way against really bad odds. So thanks, everyone. And with that, take a motion to adjourn from Mr. Danby. And Gino will second that, and I'm not even gonna take a vote on that. We are adjourned.
hey, John, if somebody can collect these.